Thank you for joining us today for our course on documentation strategies to minimize risk. We want to welcome the WI, the Women in Ophthalmology, to this course. My name is Michelle Pineda, and I'm a risk manager at OMIC. I'd like to thank Dr. Fine, who is a member of OMIC's Claims and Finance Committees and a cataract and glaucoma specialist at OCB. We often get asked, why a documentation course? We found at OMIC that our claims and lawsuits each had a documentation issue. So we thought we would pick some cases, pre-op, intra-op, and post-operative cases, which Dr. Fine's going to discuss today, and give you examples of documentation and how to improve your documentation. We'll also talk about informed consent, disclosing errors. We'll talk about non-compliance and informed refusal, and avoiding documentation pitfalls in your electronic health record, text, email, and phone calls. The goal, the right care at the right time. At the end of the day, that's what really matters. This was stated by the Office of the Inspector General, Health and Human Services. But remember that it is critical to document that care and the reasoning, document that care and reasoning carefully. The importance of medical records. We are told by a lot of our defense attorneys that the cases are indefensible due to incomplete or inaccurate documentation. Today, we will show you a few examples of this. Poor documentation makes good care look bad. If it's not documented, it didn't happen. Documentation is a reflection of your thought process, rationale, and considerations. This is just a chart to show you the likelihood of a claim in a 30-year career in medicine. 3+ claims, 31%, which means really a probability of a claim in a given year is about 8%. 14% of OMIC claims involve a diagnostic error. And the diagnostic errors represent 34% of claim payments. What elements need to be included in the medical record? It needs to be clear and understandable, accurate, concise, legible, logical train of thought, and easily accessible. Who will see your medical record? I often say that it's a representation of you before they ever even get to meet you or see you. Lawyers review your medical records, the judge, the jury, witnesses, the public, and of course, the patient. And how will it be interpreted? The following is the elements of a medical malpractice lawsuit. We call it the 4 Ds. Duty to treat. Deviation from the standard of care, which requires expert testimony. What would a reasonably prudent ophthalmologist do in the same or similar circumstances? Direct causal relationship between the deviation and the alleged injury damages. We call that the proximate cause. And of course, last but not least, damages, actual economic and non-economic. At this point, I will turn it over to Dr. Fine.
Thank you very much, Michelle, and thank you to the members of the Women in Ophthalmology. We're going to talk and review some of the specifics of what should be documented in the medical record. And, this is typically what you all are doing, I'm sure, but just reviewing it and how important it is to document all these essential elements. I think this is really worthwhile a moment to discuss. So the pertinent clinical history, you want to review the history of present illness, the chief complaint of the patient, what brought them to the office. Carefully document their clinical examination and really be careful not to carry forward any exam elements that aren't current, and note anything specific about the patient. Instead of carrying forward all normal exam elements, really home in on what are important exam elements for that patient. Diagnostic testing that you order needs to have a reason that you ordered it and also an interpretation. What did you find in that testing? Then, of course, reviewing your differential diagnosis, what could be happening with this patient, and then arriving at what you think is probably happening, your diagnosis, and a treatment plan with recommendations and any alternatives. As far as side effects and potential complications, there should be a thorough discussion that's also documented. And then what is your follow-up plan? When do you want that patient to follow up with your recommendations or to follow up with another exam? It's important also to review other courses of treatment if your current treatment plan does not work, and then to document those. Next slide, please. So shifting gears, we're going to talk specifically about the things that are important to document when you recommend surgery for a patient. Next slide, please. When you recommend surgery for a patient, it's important to document why it is that you think surgery is indicated. What do you hope to fix, and why is surgery the best way to do it? This will aid other providers and also aid you should a claim be filed. It'll aid you in the defense of such a claim. Next slide, please. So what do we mean by a good informed consent process and documenting that process? Next slide. What is informed consent? Well, this is just a verbal agreement that we have after a thorough discussion as surgeons with our patient. We're going to be discussing the diagnosis and our proposed treatment, any risks and benefits, any alternatives and potential complications of what we propose, the procedure we propose. And it's important to also review the consequences if they were to refuse treatment. What might happen if they decided not to pursue surgery? The documentation of informed consent should be done in the medical record always. And ideally, a procedure-specific consent form would be used. We just, for instance, at OCB, revamped all of our consent forms so that our trabeculectomy consent form is a little different from our cataract surgery consent form in terms of what risks and benefits we review and the potential complications. And also, we tried to do in plain language kind of create a document that reviews what goes on in that procedure. But this really memorializes the consenting conversation, this whole documentation that you're doing, so that, you know, if you review anything that specifically the patient had concerns about and document that, that's a robust way to really memorialize your conversation. Next slide, please. So what happens when we don't document well our informed consent? We are going to discuss a case in which the standard of care may not have been violated, but the informed consent was lacking. And this patient sued after they developed double vision, and this happened because of excessive scarring when a lid lesion was removed. The problem was there was no documentation of any reason that the lid lesion was excised, any chief complaints, any reason that the surgery actually happened. And when this patient experienced just a rare idiosyncratic immune response and severe scarring with resulting double vision, the defense expert felt that the scarring could not have been anticipated, so that was okay. But another defense expert criticized the lack of documentation about why the procedure was done in the first place. So the case ultimately settled for $95,000, and that was really due to just a lack of informed consent documentation. Next slide. So in terms of our preoperative process, just really highlighting the importance of consent, there's another case here of a cosmetic chemical peel. And next slide, please. In this case, a 62-year-old woman had a cosmetic chemical peel, and she developed an infection and a facial scar from her cheek to her upper lip secondary to the infection. Next slide, please. So Well, there may not have been any deviation from the standard of care that, an infection is a possible risk of any procedure. The problem was that there was a lack of a documented informed consent or discussion, and there was no chief complaint again. So very similar to the other case we just mentioned, and no discussion of the possibility of infection with procedure. So the case went to trial. The surgeon offered to settle for about $10,000. This wasn't accepted, and there was a 2-day trial, which ultimately resulted in a defense verdict, fortunately. But despite the defense verdict, the expenses to defend the case were substantial. They were $125,000. So, the informed consent process and documenting it is just very, very important in terms of showing people what your intention was with the patient and then being able to defend a claim when it happens. Next slide, please. Now we're going to shift from preoperative documentation to documentation issues regarding intraoperative care. So this was a case, a retina case. Next slide, please. This 48-year-old woman complained of foggy vision and a sudden decrease in her vision, which was at that point 20/50 in the right eye and 2200 in the left eye. She had a complicated medical history. She had just been hospitalized for a deep venous thrombosis and placed on Coumadin. She also had hypertension and type 2 diabetes. Her diagnosis in terms of her ocular problems was proliferative diabetic retinopathy and macular edema, left eye greater than right. And she underwent pan-retinal photocoagulation and Avastin injections for a couple of years, maintaining good vision with those treatments. But then she developed the sudden onset of vitreous hemorrhage in the right eye. And the surgeon recommended and planned a vitrectomy with endolaser, which was done 2 weeks after the vitreous hemorrhage occurred and the patient was examined. Unfortunately, during the surgery, there were some unanticipated bleeding, and shortly thereafter, the patient developed no light perception vision in the right eye, very poor outcome. So this was a complex patient. The problem was there was also poor documentation. For instance, it was unclear who was actually performing the procedure. Next slide, please. And in the review of this claim, the reviewers felt that the poor outcome was likely based on the underlying risk factors in medical health, ocular health, but that the poor documentation made the case very difficult to defend. So, for instance, other non-surgical options might have been available, but a discussion was not documented of these. And then there were some questionable care by providers and staff on the team. The outcome was that the case settled for $600,000, and this was in a state that had no cap on damages, and this led to a pressure to settle. Next slide, please. So as far as the documentation issues, it's important to note that you need to kind of look at what evaluation was actually done and documented. But specifically, there was a lot of carry forward in the notes, and there was inadequate documentation of what drops were used to control the eye pressure. There was an elevated eye pressure on the first day after surgery. When a procedure was done to lower the pressure with a tap, the post-treatment pressure was not indicated in the chart. Also, as far as lack of informed consent, specifically treatment options, alternative to vitrectomy and endolaser, there was a lack of documented discussion about anticoagulants prior to treatment. This patient was on Coumadin. And most notes kind of carry forward normal on all the visits, even when the patient's eye went into ptysis. The pressure wasn't checked or documented routinely, and the SF6 gas amount and concentration were lacking in the chart, and this likely caused the increased pressure. It's also unclear when the pressure was very high who performed the paracentesis, and there was no MD in the office, so it could have been an ophthalmic technician. So there were many problems with documentation, and this resulted in this settlement. Next slide, please. As far as now, we've reviewed intra-op and we also reviewed pre-op. Now we're going to shift to post-operative and clinical care documentation and its importance. In this case, revolves around late diagnosis of glaucoma. Next slide, please. So in this patient is a 70-year-old woman who complains of tearing and blurred vision. She's treated for many years for dry eye, and the treatments include topical tears, cyclosporins, punctal plugs, antibiotics, steroids, and intense pulse light therapy. And this is both by the treating MD and OD. She then developed cataracts over a 2-year period, likely secondary to topical steroids, and premium lenses were placed. With one of the eyes of the left eye, there was a residual refractive error, and subsequently a piggyback lens was placed on top of the existing lens to address that residual refractive error. This patient then developed pigment dispersion and problems with their intraocular pressure. The complaints that they had were numerous: blurred vision, a diminished field of vision, depth perception issues, glare, sensitivity to light, and smudging of their vision in the left eye. And the clinical course was such that they had a late kind of discovery or diagnosis of low or normal tension glaucoma. And pachymetry, visual fields, and glaucoma and neuro-ophthalmologic consultation weren't performed until the cupping had increased to 0.9 cup and an afferent pupillary defect were found. The problem also was that they changed the electronic medical record during treatment, and this caused some confusion in the documentation as well. But there were many things, risk factors, that could have led the treating ophthalmologist to do more testing earlier on. This patient was on steroid drops, had elevated pressure, and also a family history of glaucoma. Next slide, please. So a claim was filed, and the demand was for $750,000. Defense counsel estimated a $200,000 to $250,000 settlement range, and the case ultimately settled for less than that, $162,000. 60% of the liability was attributed to the practice, secondary to system failures, including participation of the optometrist in the practice and supervision issues of the optometrist, and then 40% to the physician directly. Next slide, please. So as far as documentation, we had mentioned they had been in paper charts and then switched over to the electronic health record. And there was poor documentation of medications in that record. Also, the problem list was incomplete, especially no notation of a steroid response. It was difficult in reviewing the chart and the electronic medical record to really follow the thought process of the treating physician and what prescribed medications, why they prescribe certain medications. Diagnostic tests were listed in the record but could not be found, and it was unclear if they were interpreted. There was co-management, which is another factor in this claim between the MD and the OD. There seemed to be some lack of communication and a lack of oversight that probably led to a delay in diagnosis of the glaucoma. When there was a failure to diagnose the glaucoma, the optometrist, and the medical doctor were documenting their optic nerve exams and following the patient closely, but the optic nerve exams were not consistent ultimately with the specialist that saw them. They did ultimately see a glaucoma specialist, and the optic nerve that they had been documenting really was not cupped to the 0.9 degree that the glaucoma specialist ultimately said that they were seeing. So was the optic nerve really being looked at, or were they missing the finding of the cupping? There was a failure to interpret studies, a failure to conduct proper testing and to monitor the patient. And then it is concerning that there was a lack of a protocol for medication refills. So refills were provided without checking with the physician, especially for the steroid drops. So this highlights how important it is to have protocols in your practice about how to refill medications. Next slide, please. So now we're going to shift from documentation of your kind of treatment plan and consent process to how to deal with errors when they occur. Next slide, please. This is a case of PRK, and it highlights a failure to document a disclosure of a medical error. Next slide, please. So the patient was a 46-year-old woman who presented for refractive surgery, and she wanted to be glasses and contact lens independent. Preoperatively, she had a fairly mild prescription, minus 1.25 for the right eye and minus 0.75, and with that corrected to 20/20 in both eyes. The surgeon recommended PRK to achieve the glasses independence, and this was performed with no complications. She had had a history of LASIK 2 years prior, and before the procedure, the chief complaint was blurred vision, diminished field of vision, depth perception issues. Actually, this is after the procedure, I'm sorry. Blurred vision, diminished field of vision, depth perception issues, constant glare, and a sensitivity and smudging of the vision in the eye. PRK, unfortunately, fortunately was performed with no complications. But next slide, please. On post-op day 1, her vision was 20/250 in the right eye uncorrected and 21/50 in the left eye uncorrected. So this, after PRK, you do have some blurred vision, but this was a little bit worse than might have been anticipated. And at 14 days postoperatively, the insured ended up checking the laser record and noticed that there had been a transposition error. So plus 1.25 was entered in the machine instead of minus 1.25 for the right eye. And then the day after, there was an 8-minute phone call to the patient, but no documented discussion, no written, documentation of what was discussed. And the doctor indicated he asked the patient to come in to discuss this in person, to disclose the error in person rather than over the phone. Next slide, please. So the plaintiff, their allegation is really there was a failure to disclose the error postoperatively. And the problem was the medical record has no mention of this transposition error. And the patient ends up finding out about the error 6 weeks after the procedure from a discussion with one of the insured's technicians. So punitive damage claim was also made due to concealment. So it was really felt by the plaintiff that this information that the surgeon had was being concealed from them. And it was settled in mediation for $200,000 because there was an error in the treatment, but just as significant was the alleged concealment. And the physician discussion just simply was not documented. So this is a real issue when perhaps the surgeon really meant to disclose this error, but didn't follow through, and there's a lack of documentation about their efforts to have the conversation. Next slide, please. So we're going to just review, lastly, an issue of non-compliance and refusal of care, which is equally important to pay attention to documentation. And this is an ROP case. Next slide, please. So this was actually a call to the OMIC hotline, and if any of you have ever used the hotline, it's a great source of advice and information. But in this case, the insured called saying that parents were refusing to return to their facility according to their primary care, and they needed follow-up for ROP, and this was documented that they were failing to return. It was documented in their health record. They were twins born at 28 weeks gestation, and their ROP risk was really great. They didn't show for 2 weeks in a row. The parents' refusal to show was well documented, and the ROP treatment options were limited in their area, so that the insured was one of the only people that could see them. On the hotline, the risk management advice to the insured was to contact Child Protective Services. And next slide, please. The outcome was a timely action to save this baby's eyes. And when you can send a certified letter to parents and call Child Protective Services, this can possibly reduce the risk of a later claim or lawsuit. And OMIC has spent a lot of time on developing resources on ROP, and there's the ROP safety net. Many of you may be familiar with this, especially those that treat ROP regularly. There are a lot of resources to really help protect our patients, but also to help protect us when we're dealing with a high-risk situation such as ROP. And Michelle, you have a lot of experience with this on the hotline and with the resources on the website. I wonder if you could review a little bit more about this.
Thank you, Dr. Fine. Yes, ROP cases are some of the highest paid claims, unfortunately, at OMIC. And you can only imagine if a baby, goes blind, it costs a lot of money to take care of that child for the rest of their life. As a result, some of the board members and risk managers got together and developed a very comprehensive safety net. And it actually gives sample protocols for in the office and for the hospital, actually, and comprehensive letters. And it's very step by step. And so we do get a lot of phone calls about it, and we are happy to share it anytime. So if you do have a question about it, feel free to call the hotline and you will get one of the risk managers. So let's talk a little bit about the documentation for the ROP case. You want to talk about the care that's needed, and if that's just a reoccurring appointment, as the case discussed previous by Dr. Fine, it really was just a phone call saying, look, I've got parents who are not bringing their twins in. I'm very worried about, the babies. So you want to document the discussion with the patient, which would be the parents, the patient's reason for non-compliance. Why are they not coming in? The risks obviously are blindness, and the consequences are pretty severe. So either send a refused care letter, which we have a sample on the website, via certified mail, if serious. Have the patient sign a refusal of care consent form. The refusal of care consent form comes in handy too with elderly patients who, are well into their 90s, and they're just sort of done with having any more serious eye treatments. And, it could be a patient that you've treated for 30 plus years and they just decide they don't want to have that laser treatment, or they don't want to get those injections. But you really, have enjoyed treating this patient and you want to continue to treat the patient. So this is where a signed refusal of care is important. Again, all of these resources are available on the website. So let's move to technology. Electronic healthcare record pitfalls. I speak a lot on this topic, and I always get people in the audience huffing and puffing. No one really likes their EHR system. There's so many different, electronic healthcare record systems out there. Some are very comprehensive, some are better for ophthalmology, but it's a computer. So, you want to pay attention to where the errors come from. And we've done research on this topic. We've looked at our own cases, and it's about 50-50 user versus system errors. With system errors, it's really all about making sure you get your upgrades and you contact your, vendor if you're having issues that are really causing havoc at your office. Sometimes they can turn some of them off. Sometimes they might upgrade the software at a later date and they will implement that change. You want to ask if there's a workaround. And then with user issues, really it's a training. It's a training issue. If you designate a super user, there's always somebody in the office that likes computers or is really good at it, and they can generally help people who don't have as much training, to learn the system. Be careful delegating privileges. We have seen physicians delegate their privileges to techs to go in and do something in the record. And unfortunately, that is disclosed at a later time because there's metadata and there's audit logs, and plaintiff attorneys have gotten very smart about asking for those. So they ask for the front office and the back office information, and then that's brought to a deposition. What are some of the pitfalls? Copy and paste and carry forward and cloning. At this point, I'm just going to let Dr. Fine share how OCB, uses their copy forward.
Yeah, I think that it's important to understand the limitations of the electronic medical record, that, we have these customized paragraphs that can be pre-populated, that review consents for cataract surgery, but we want to go and edit them for the individual. So you don't want to put everything in the record and carry it forward and then fail to go back and pick and choose what is particular to the patient. You need to go back and kind of refine what you have selected. So for instance, if you're recommending cataract surgery, it's nice to really remember to document, well, what particular problems is this patient having? Mrs. So-and-so is having problems seeing her piano and gardening, is much better than just having a very generic reason for surgery, because it shows that you listen to her complaint and that it's specific for her. So the other thing is to just make sure that part of your record doesn't contradict another part. So this happens when you carry forward something from another date and you fail to indicate or take it out. So it's really just about reviewing what you've written and editing it for that particular date. Often I will, if I do a procedure and I note it either in the slit lamp exam or in the assessment and plan, I'll put the date in front of the procedure that I did, and then I'll say what I did, injected a few into the bleb, because then if I see the date the next time around, I'll take it out because I know that that's not pertinent for the date. Anyway, there's a lot of problems that you can fall into, a lot of pitfalls of the electronic health care record if you're not going back and reviewing these things or teaching your scribes to help you with that.
Exactly. Dr. Fine, I wanted to ask you one question about amending a record. How does it work in your system when you go back? Let's say you're reviewing your op note or you're reviewing a previous visit and you see that something isn't right. How do you amend your record?
You can amend it, but there's always going to be a history of what was written prior. So if you can date when you amended it, and indicate the change, just remember that what has been there before will still be discoverable, either directly visible or somehow searchable. So I think that you can amend things, but the original document will also be there. So just be very clear and date it and say what was erroneous and that you're correcting it.
Great. Sharing passwords, really just don't do it. It has to be there has to be a really good reason to share your passwords. A plaintiff attorney will depose a tech or a scribe or somebody who logs in as a doctor. And once that's disclosed, it takes the whole medical record into question. And you don't want to be put in that position. Text messaging and email. CMS has made a statement about text messaging. Texting patient information among members of the healthcare team is okay if through a secure, portal platform. A lot of practices have that now. You want to make sure your text is professionally written, and that you are not giving, patient care orders over an unsecure system. Computerized provider order entry is the method for submitting orders, which that has not changed. Email, if your patient consents to use email right off the bat, then you're typically okay. You want to limit the amount of PHI, that personal health information that's disclosed, especially when using an unencrypted email source like Gmail or AOL or whatever the patient is using, especially if you are not using an encrypted system. Don't practice medicine over email. Make sure info gets into the medical record. The patient has the right to opt out of email. We did have a situation, a hotline call, where it was an oculoplastic practice that sent out a special on Botox. And they thought they put all of the email addresses in the blind copy section of the email, and they actually put it in the to section. And one of the recipients was an administrator at a big hospital, and she was not exactly very happy that everyone knew that she was, a patient at that practice, and it suggests that possibly she used Botox. Something to remember about digital and electronic devices: phone records and emails are discoverable. Assume someone can read over your shoulder. We're always looking at our devices, and I don't know about you, but my font's pretty big now because I don't see as well as I used to. Make sure to lock your phone, have the ability to remotely delete PHI if your electronic device is lost or stolen. Documenting your phone calls. You want to document all calls. I have seen a couple of our cases, lawsuits, where, it was an after hours call and it was the middle of the night and it just didn't get documented. And the doctor has to later go back and explain that in a deposition. And it, is obviously not as good as the first time around if you, get it in the medical record. So you want to document after hours calls with patients, while you're on call, patient sign-offs when going on or off call or transferring care. Telephone call documentation should include the date, the time, the information obtained and given, the assessment, recommendations, follow-up, communication with other providers. We have an excellent video on telephone screening that staff find particularly helpful. And it's on our YouTube channel. If you go to Ophthalmic Mutual Insurance Company, you will see it there. We also have sample screening guidelines, contact forms for calls to staff, and for after hours calls. More resources that you might be interested in that are also on our website regarding termination of care, referrals, transfer of care. We really have just about everything. And if you can't find it on the website, just call the hotline and we'll be happy to send it to you, email it to you. This course will qualify you for your risk management discount. I want to thank Dr. Fine for joining me today. It was our pleasure and privilege, and we hope that you enjoy the course.
Thank you very much.